Hello everyone, this is Dr. Pritpal Singh, an MD in pharmacology from CMC Ludhiana. And today I'll be talking about one of the competencies in the CBME curriculum of the undergraduates, that is PH1.17, which says describe the mechanism of action, the uses, the adverse effects, the doses, the indications, and the contraindications of local anesthetics. Now, in one of my previous sessions, I started with the types of local anesthesia, its differentiation from general anesthesia, the classification of local anesthetics, and the various techniques of local anesthetics. Now, in this session, we'll be proceeding beyond that with the prototype drugs that are there and the uses, the adverse effects of these drugs, and we'll be talking about the commonly used drugs that are there, and we also talk about why adrenaline is combined with local anesthetics. So I hope you have a good insight into this particular topic, and if there are any queries or any questions pertaining to this particular topic, you could write down on the chat box and I'll definitely get back to you. So let's start with the recap of what we did in our previous session. In the previous sessions, we started with the definition of the local anesthetics, which say that it is a reversible loss of all sensory sensation perceptions. And when we talk about sensory perceptions, we are talking about pain, and we say that this is because we talk about, and if there is motor, it could also, motor nerves are also blocked, then it could lead to muscle relaxation also. So now these local anesthetics are divided into injectable, which were divided into low potency short duration, intermediate potency and duration, and high potency and duration. In the low potency short duration, we had propane and chlorprocaine as an example. In the intermediate potency and duration, we had lidocaine and prilocaine as an example. In the high potency long duration, we had tetracaine, bupivacaine, ropivacaine, and dibucaine as examples. Then we talked about the surface anesthetics. Obviously, they could be either lipid soluble, which will be soluble anesthetics, or they could be lipid insoluble, which is insoluble anesthetics. In the lipid soluble anesthetics, we have examples of cocaine, lidocaine, tetracaine, and binoxynate, whereas in insoluble, we have benzocaine, butyl aminobenzoate, also known as butambaine, and oxyethazine that are commonly used as insoluble surface anesthetics. Now, when we talk about the various techniques of local anesthetics, we started with in the previous session, we started with the technique of infiltration anesthetic, where with the help of a needle and syringe, we inject a relatively large amount of drug into the deeper tissues and the skin, and minor surgeries such as incision, excision, and hydrocele operation could be performed with this. The next was conduction block, which could be where this particular local anesthesia is injected around the nerve trunk and never into the nerve, because it could lead to pain and nerve damage. So this conduction block could be either field block or it could be nerve block. So when we talk about field block, we try to block all the nerves coming to a particular field, and we do this when we are talking about forearm, leg, and scalp. Whereas when the nerve block, we try to block a particular nerve, and the procedures which can be performed under nerve block are dental procedure, limb procedures, eyes, as well as fracture settings. The next technique that we talked about in the last session was the IV regional anesthesia, where we try to have regional anesthesia distal to the pressure curve, but this could be only used for few anatomical regions. To be more precise, it could be used for forearm and hands, and it is effective till the circulation is restored. Uses hardly 15 to 30 minutes, and pain returns very quickly. The tourniquet is released earlier, it could lead to systemic toxicity, and if it goes beyond more than 2 hours, it could lead to pain as well as ischemic nerve injury. The drugs that are commonly used are lignocaine and prilocaine. Obviously, when we are talking about lignocaine, it should not be used with adrenaline. The spinal anesthesia is where we tend to inject local anesthesia into the subarachnoid space between L2 and L3 and L3 and 4. Now it acts on the lumbar and sacral root, and the intestine is contracted. The advantages of general anesthesia that it's safe, it provides good analgesia and muscle relaxation, there is no loss of consciousness, and it could be used in all sort of patients, all category of patients which could have cardiac problem, renal problem, pulmonary or diabetic patients. The drugs that are commonly used are lignocaine, bupivacaine, and tetracaine, where adrenaline could be added to increase the duration. It is useful for the procedures of lower abdomen, pelvis, and lower limb. The adverse effects associated with spinal anesthesia are hypotension and bradycardia. It could lead to respiratory depression. It could lead to headache. It could lead to meningitis or hematoma, and it could also cause post-operative urinary retention. Now, there are certain contraindications to the spinal anesthesia because it requires a certain specific set of position by the patient. So it could not be given in uncooperative patients, in mentally ill patients, in infant and children. It should not be given in hypotensive patients, where patients who have hypovolemia, and patients with an abnormal spinal cord. The other technique that we talk about is the epidural anesthesia, where the drug is directly injected into the epidural space, where the spinal nerve root are targeted, and we try to go for the caudal, lumbar, thoracic, or the caudal area. Now, the disadvantage of this particular technique, as with reference to the spinal anesthesia, is that a high concentration of the drug reaches the blood. It is difficult, and a large volume of drug is required. Although its uses are similar to spinal anesthesia, it could provide good post-operative analgesia, could lead to painless labor, and continuous epidural anesthesia or analgesia is always a possibility that is there. The topical anesthesia is where we tend to anesthetize the mucous membrane. The adrenaline and lignocaine and tetracaine are used in the form of 2% cream or jelly or gel. Adrenaline is not used out here because adrenaline has poor penetration and it cannot prolong the action of local anesthetics. Now, local anesthetics can be absorbed into the systemic circulation, leading to systemic toxicity. Now, this is another special preparation of topical anesthesia is the eutectic mixture of prilokinine and lignocaine, which is also under the name of EMLA. Now, eutectic mixture is where the melting point of the combination is less than either compound alone. It is oil at room temperature and it can always penetrate an intact skin. Now, what do we do? How do we apply this cream or oil on the intact skin? We apply it under the occlusive dressing, and this is left for more than 1 hour. And it could be give you a proper anesthetic technique to the particular area where it is anesthetized. But there are certain areas or certain special precautions. It should not be used on mucous membrane or on abraded skin because it can lead to rapid absorption and systemic toxicity. Moving beyond this, now these local anesthetics are divided into two broad categories. They are either Eastern-linked local anesthetics or amide-linked local anesthetics. Now, as compared to Eastern-linked local anesthetics, amide-linked and local anesthetics are preferred because they are more intense and long-lasting as compared to amide local anesthetics. They do not cause hypersensitivity reaction, which is quite high with Eastern-linked local anesthetics, and these drugs being slightly a basic bind to the alpha-1 acid glycoprotein in the plasma. The commonly used Eastern-linked local anesthetics are cocaine, procaine, chlorprocaine, tetracaine, and benzocaine, whereas the commonly used amide-linked local anesthetics are lignocaine, bupivacaine, dibucaine, prilocaine, and ropivacaine. The mechanism of action, if we talk about it in one particular line, it says that it inhibits the entry of sodium into the voltage gated sodium channels. The lesser entry of sodium, action potential is not generated, and depolarization does not occur. So the area is the sensation to the area is lost. Going beyond this, the sodium channel exists in three states: the active state, the inactive state, and the resting state. This particular drug binds to the inactive state. With continuous presence of this drug, the upstroke of the action potential keeps on decreasing till a particular moment when the sensations, when the transmission to the particular point, particular nerve is totally interrupted. Now, when we talk about its action, or beyond this, when we talk about its action, it is amphipathic in nature. It must cross the cell membrane and it has to bind from within the cell to its site of action. Now, being amphipathic, it can easily cross the cell membrane. It's ionized and it binds to them inside of the cell membrane, where it binds to the sodium channel, and it binds to sodium channel more preference towards the inactive state, decreasing the upstroke, causing loss of sensation. The localized action of these are that it acts on all the types of sensory nerve endings, neuromuscular junction, ganglionic synapse, and nerve ducts. Now, when we talk about the receptors, the smaller nerve fibers are more prominently affected as compared to the larger fibers. The non-myelinated fibers are more affected as compared to the myelinated fibers, and the autonomic system is more affected as compared to the somatic system. Apart from this, we have certain systemic actions that are there. Now, when we talk about soluble anesthetics, we gave you an example of cocaine. Cocaine is a drug of addiction. So when we talk about CNS, there is a special mention of cocaine because it causes stimulation. Now, this stimulation is followed by depression. Now, this stimulation results in euphoria, mental confusion, conversions, respiratory depression, and death. Whereas on the other hand, lignocaine causes drowsiness and lethargy. In the cardiovascular system, it causes cardiac depression, and if it given in high doses, it can act as an antiarrhythmic drug. And when it is given in high plasma concentration, it could lead to cardiac arrhythmias. In the blood vessels, it tends to decrease the blood pressure, and cocaine, because of its action on the sympathetic overactivity, it could lead to a prominent rise in blood pressure and heart rate. Now, talking about these drugs, the most common drug that is used is lignocaine, which has a rapid onset of action. It has few side effects, and it is there for almost all types of anesthesia as well as ventricular arrhythmia. Prilocaine is a medium efficacy drug, and it causes methemoglobinemia. It is used for infiltration, nerve block, and IV regional anesthesia. Tetracaine is a slow-acting drug, and it is used for various mucous membranes as well as the spinal anesthesia. Bupivacaine being cardiotoxic, we have lesser cardiotoxic drugs such as levobupivacaine or ropivacaine that are available, and it could be used for infiltration, nerve block, epidural, as well as spinal anesthesia. Apart from this, we have dibucaine, which is used for spinal anesthesia, has a longer duration of action, and it could also be used on surface anesthetics for less delicate mucous membrane, like the mucous membrane of the anal canal. Penoxinate could be used as a for corneal anesthetic. Benzocaine or vitambane has poor absorption, so it is commonly used in preparations for stomatitis, sore throat, wounds, or anorectal lesions, whereas oxyethazine ionizes at low pH, and it is common preparation in gastric mucosa for use for gastritis and heartburns, and it is also used in irritable bowel syndrome, where it decreases the postprandial urgency. Now, coming to the last part of this particular presentation, why adrenaline should be combined with lignocaine for local anesthetic. Now, adrenaline has a property of vasoconstriction. Now, because of this vasoconstriction, the blood supply to that particular area is decreased, so it prolongs the duration of action of anesthesia. Now, as due to lesser blood supply, the systemic toxicity is less, and due to lesser blood supply, blood loss during surgery is less. But there are certain disadvantages also. The disadvantages are that this injection is more painful, there are high probability of local tissue edema and necrosis, and there is all possibility that it can lead to a rise in blood pressure as well as arrhythmia. The other thing that is to be kept in mind is the combination of lidocaine and adrenaline should not be given where we have an artery, because it could lead to necrosis. So this is all about the topic of local anesthesia. I hope I have been able to clear some doubt or some insight. I've been able to give some insight into it. If there are any queries, you can get back to me. I'll be happy answering them. Have a nice day and happy learning. Thank you so much for your patient hearing.